And so we call it toxic because this stress is acting almost like battery acid, and it's leaking through the body, and it's slowly corroding our physical health, our mental health, and our emotional well-being.
Welcome to the very first episode of Nurturing Humboldt, a podcast brought to you by First 5 Humboldt. Here, we'll explore the ways our community is transforming care for children and families. I'm your host, Karina Vasquez, and today we're scratching the surface on a deep conversation about adverse childhood experiences, ACEs, and how they shape lifelong health. To kick things off, we're honored to feature Dr. Michael Mangahas, a local pediatrician who has served in nearly every hospital and clinic in Humboldt County, serving all of the kids in our area. He's on the front lines of shifting how providers talk about trauma, resilience, and healing. This episode is just the beginning of our multi-part series on ACEs and the beginning of this podcast series together. So let's get started. Well, thank you, Dr. Mangahas, for joining us. I'm so excited for you to be here. I would love if you could give us a little bit of background about you and why you became a pediatrician.
Sure. Thank you so much, Karina. I'm honored to be on this podcast. So my name is Dr. Michael Mangahas, and I'm a pediatrician. I was originally born in the Bay Area, but I grew up in the town of Mendocino. And then I went to school at University of California, San Francisco. And that's kind of when I first started becoming interested in becoming a pediatrician. Initially, when I went to med school, I thought I was going to be a surgeon. I like working with my hands. I love to cook. But on my pediatrics rotation, I had this one patient that just stuck out to me, and it changed the whole trajectory of my career. I had a 4-year-old girl come in to San Francisco General Hospital who had a history of asthma and was really, really sick and was very weak and not waking up very much. And so we were giving her medicine from a mask, a thing called a nebulizer that helped her to breathe. And as the medicine worked and she started to be more alert and feeling better, she became more like a normal 4-year-old girl and didn't want to wear the mask, didn't want to take the medicine, was kind of punky, and was hard for the nurses to take care of her. And right next to her room was an arts and crafts room that wasn't being used. And so during some downtime, I went into that room and I made a dragon mask out of some foam and some construction paper, and I taped it to the nebulizer, and it worked, and she loved it, and she was able to do the treatments. And that kind of sealed the deal for me, because I realized medicine is so much more than just knowing the right medicines and how to do it, and kind of understanding diseases, but it's really about that interface between the doctor and the patient. And any treatment plan is just a plan until it actually works. And so I felt this almost this little bit of magic where I was like, wow, this actually is fun. And I was able to do something unique that felt responsive to that patient's needs. And so from then I said, okay, I'm going to be a pediatrician. And, there's a lot of myths that go along with pediatrics where, oh, it's 2 patients, you have to take care of the parents and the kid. And to some extent, that's kind of true, but I do enjoy that. And so I kind of decided to become a pediatrician.
I love that. I feel like there is a lot of magic in that story, and it's almost like you found your calling, but it also found you all in that moment. How has it been for you being a pediatrician up here in Humboldt?
It's been both really amazing and a challenge, right? We live in a extremely rural community, and so we have, one, not enough physicians to take care of the number of patients that live here, and 2, not enough resources for the patients who are really sick. But I think what's so amazing about being in a small rural community like this is I have so many multiple touch points with families throughout the community. I live here, I work here, and eventually, hopefully, my kids will go to school here. And so there's all these opportunities to see families outside of the clinic and outside of the hospital. And, they're my neighbors. They're the people that I go buy groceries from and buy vegetables from at the farmer's market. So I really enjoy that.
Yeah, I think you speak to something that we all know here in Humboldt. I mean, it's so rural and we lack a lot of resources, and yet there is so much strength in the community. I grew up in the Bay Area, and coming here, I think I was afraid that I wasn't going to find community, and yet I found something like I have, and it's a little bit more wholesome in a way because it's more intimate.
Yeah.
So what do you feel like with Humboldt and our Humboldt kids are some of the most common concerns that families are coming to you about their kids or maybe overall community health that you see?
It's interesting. I think, well, it's really seasonal, and here we are coming out of winter and into spring, and the most common illness or thing that I'm seeing in clinic right now is our colds and the flu. But once you get past that, I think the most common thing that I also see, especially in some of the smaller clinics that I travel to, are concerns about the behavior and development of a child. And so many times a parent will say, I'm not sure if there's something wrong with my kid, or it's really challenging because of X and X behavior, or they're not doing great in school, or I'm worried that there might be something wrong. And there's a lot of comparison amongst their kid to other kids, either similar age, cousins, or other kids that parents might have seen at school.
Is there advice that you give or like a general kind of conversation that you have with parents about overall well-being and kind of taking away that comparison?
Yeah, I think it's kind of trite, but sometimes parents will volunteer it too. They'll say, I know every child is different, almost kind of like a yes, but I lean into that and I say, yeah, every child is different. And I think the other thing that I try to tell parents is that one of the skills of pediatrics is the way that we approach a patient is it's a timeline, and a kid is in a constant state of developing new skills and behaviors. Sometimes the development of those behaviors is the normal track. Sometimes it's not the typical track. But in any case, we're taking a snapshot of a kid in a moment in time when they're in clinic and trying to assess what they can do and what they know already and what they don't already know and are not ready able to do but are working on. And how do we get that kid from one stone to the next stepping stone?
You bring up such a great point about, typically when we see a healthcare professional, we're there to address like an immediate concern. So maybe that's the flu, maybe that's, something like that's causing you physical pain. But when we talk about things like developmental behaviors or other concerns that caregivers could have, I think this perfectly ties into the topic of today, and why I wanted to have you on the podcast is to talk about what else could be happening beneath the surface, or what else is the story, right? What is happening in the family system? What could be happening that's triggering the kid? What other things are, what's the story that's being told, the whole story? We've gotten to work together and kind of seen you from the provider perspective, and then, First Five coming in afterwards and talking with parents, around what concerns came up. One thing that I've noticed is, when we have conversations with caregivers around their kids and they're focused on the kid's behavior, or maybe, my kid right now is experiencing a lot of anxiety or having a lot of feelings. They look really sad. And in conversations, something that I reflect on a lot is asking the caregiver, well, how are you doing? And what's going on with you? And it tends to be a great way to kind of think about whole family well-being. And, it starts with us taking care of ourselves and then being able to, respond to our kids. And it's not always the case that, caregiver well-being is reflection of what's going on with the kid, but oftentimes it is. And so I think it's great that we are able to kind of educate and also kind of take a little bit of guilt away and have some reflection in it's the story that's being told, the whole story. And so we are going to dive into adverse childhood experiences, also known as ACEs. Adverse childhood experiences are basically things that could have happened in our childhood or are happening in children's lives that could potentially impact them in some ways as they get older, or have impacted us now as adults. And I would love if you could take us through your definition of ACEs and how you talk about ACEs with families. And yeah, let's kind of dive into this topic.
I think that's absolutely spot on, Karina. I think the thing that you can't discredit is that a parent or a caregiver or a mother or a father, they're also people. who come into the relationship with their kid with their issues, their challenges, their own medical health conditions, their own mental health conditions. And oftentimes it gets discredited as the patient is the kid. But it's a family systems. So the way pediatricians think about ACEs or adverse childhood experiences is we break it up into kind of three categories. And the three main categories are experiencing and or witnessing or being in a household where there is abuse. So whether that's physical abuse, emotional abuse, or sexual abuse. Being in a household or experiencing or witnessing neglect, that can be due to a parent having severe mental health issues so that they are not able to take care of a child, or substance use and drug issues that make them so they are still also not able to take care of a child, and that child can be in dangerous situations. And kind of the third category is what we call household dysfunction. If you think of a house almost like a body, it has different parts and different organs that make it work. And any disruption to that house or to that body can cause dysfunction. And so one of the most common ones that we see is when parents separate or divorce. You go from having a house that have two caregivers to now just one. And that one caregiver has to provide all the care for that kid. And that really drains the bandwidth and the ability of that parent to do what two parents could do as a team. Some of the other things that we see is if a family is a multi-generational unit and there are grandparents or other caregivers and one of them dies, that also affects the ability and the strength of the household to have other people taking care of a kid. So those are the three main categories, right? Abuse, neglect, and household dysfunction.
All right, I just want to take a beat real quick. I want to say that it's not easy and it can be challenging listening to conversations around trauma, around childhood trauma, about the healthcare world. And so if at any point you feel that your body has been triggered and there's a stress response happening and some feelings are coming up or some emotions, to try to work through that and past it. Because I think there's so much growth that could happen when we sit with uncomfortable topics. But also I invite you to take care of yourself as you need to. All right, let's go ahead and jump back in. And so how are you approaching having those conversations with families when they come in for an appointment? When we're talking about ACEs and ACEs screening and including trauma in the conversations, what does that look like for you?
It's been an evolving practice, actually. It's really interesting. When I first started this work about 2 or 3 years ago, my approach was, let's just treat this like a vital sign. And so when we see a patient and they come into clinic, we take their weight, we take their temperature, we take their height. And one of the things that I started to do was to implement what we call universal ACEs screening, where if a kid came in for a routine checkup, we would administer a questionnaire that had several questions that got at some of these potential exposure to ACEs. And I found what it did was it allowed me to open a conversation and address that as it related to the reason why a kid was coming into clinic. Now, I've kind of been a little bit more sneaky and weaved it into just the general approach of how I talk to a family. And one of the things that I've had to transition and deal with. So initially I worked at Open Door, and now I work at United Indian Health Services. The rates of ACEs in my population now are significantly higher than the non-native population. And I knew that coming in. And I also knew that we also have a population where there has been a lot of violence towards the community and the parents. We have one of the higher rates in California of murder and missing Indigenous women. So I knew that it potentially could be very triggering to have a questionnaire bringing up some of these traumatic things. And so now how I approach it is in the same way when someone comes to me and tells me that their kid they think has a cold, I ask about symptoms. I address the ACEs also kind of as symptoms. So if a parent comes to me with concerns about behavior, I try to get a sense of what that behavior is and when it started and what it looks like. And then I kind of dive in very sneakily into when the kid was not having this behavior, what was the kind of household situation like? And who lived at home, and had there been any big stressful changes in their life when these behaviors started happening. And oftentimes parents are very aware of the ACEs and have been really forthcoming. I've had a lot of parents say, I had struggled with substance abuse problems, and my kid was taken and placed in foster care. I have a family where that placement in foster care happened kind of in the middle of the night in a very traumatic way. And it's been kind of an anchor point of her story and understanding of when her kid's behavior started. And so it's been something where I have to really respect that this is something really painful and still raw, but it's really a lot of rich information that tells me so much already, right? Like, I know that this kid not only had one or two ACEs, but had a very traumatic experience that happened rapidly. The way we approach ACEs as pediatricians is we kind of triage patients. ACEs are very common in our community. About 16% of our population have 4 ACEs by age 4. And we know from the adult studies that, 60, 70% of adults have at least one ACE, if not higher. And in our population, it's even higher than that. We think maybe 20, 30% of kids 0 to 4 have at least one. And by the time a kid is kind of school aged, it's even higher. And so that we know that it's common, we then have to kind of tease apart who are those who are really going to be affected by the ACEs. And that could be just based on the sheer frequency and severity and number of exposures that they've had, versus those who may have had only a few, but lack the resources to support them through that traumatic event. And those are the people that I really spend a lot of time with. And those are the kids where oftentimes I'll spend 2, 3, 4 different sessions just getting to know them before we start talking about how to treat their symptoms. As opposed to, there are a lot of families that I have where, like, yeah, they have on a screening questionnaire 1 or 2 ACEs, and they've also identified a lot of strengths and buffering skills that they have that they bring to the family, and the kids are doing okay. And those ones, I just kind of acknowledge their trauma and recognize that they are doing the work and offer myself as a support. But the people who are just new to this trauma, or it's still fresh, or their kids are exhibiting either medical symptoms or behaviors that are strongly associated with ACEs, a symptom we call toxic stress physiology, where we think that the severity of the trauma is overwhelming a kid's ability to regulate and to be healthy. Those are the ones where I kind of say, these are the most emergent patients. These are the ones that we really need to address, make sure that they're safe, and then also make sure that we're supporting those parents so that those kids are starting to return to a place of regulation.
I do want to take a second for those of us that maybe are hearing these numbers, 4 out of 10 ACEs, or, they could have more, they could have less. We talked a little bit about what adverse childhood experiences are. And when we look at and when we're talking about the numbers, there's this idea of the original 10 ACEs. They are based on the 3 categories that Dr. Mangahas mentioned, abuse, neglect, and household challenges. And within each of these categories, there are different adverse childhood experiences we could have experienced. So in household challenges, you might have looked at divorce, incarceration, substance abuse, domestic violence, mental illness, neglect, whether that's physical or emotional. Then with abuse, there are 3 different types of abuse that you could have experienced, or, all 3, but the category has physical, emotional, and sexual abuse. And so these are the 10 original ACEs, right? And this is what we're talking about. Many of us know that these 10 ACEs, these 10 categories here, are not the only kind of adversities that we may have experienced as children. Millions of us have experienced discrimination, poverty, racism, and other kind of impacts to our childhood that could be beyond these 10 ACEs. And so when we think about Humboldt as a whole, and then we start looking at individual communities, we can understand that other common childhood adversities beyond the 10 ACEs could look very different and are probably different depending on our culture, our communities, and what we've experienced growing up. And hardships, I think sometimes some of us tend to go for big hardships or big challenges and maybe say, well, maybe I didn't really experience trauma because I didn't experience anything in these big categories. But there are other challenges and adversities that can come up for us, taking the adult responsibilities as a child, feeling like you were the one that was taking care of someone else, experiencing big life changes for many of us who have migrated or immigrated to a new place, moving where you don't know anyone, separating from someone important, the intergenerational and cultural trauma, violence at school, like getting bullied, seeing somebody in your community get hurt, and, poverty, racism, discrimination, those things that I mentioned. So I just wanted to add a little bit more clarity around what kind of trauma we're really talking about and what these numbers mean. But as far as right now, we're really kind of taking a look at what it looks like in a provider setting when we're talking about whole family care, right? What does it look like to have those conversations with a pediatrician? What's their take? And what do they suggest to kind of improve and move forward and move through the trauma? All right, let's go ahead and jump back in. There's on numberstory.org, there's that analogy about the bear inside your house and kind of relating to toxic stress, right? So if you're out in the woods and you're being chased by a bear, your natural response and what your body's doing is going to work for you, right? The stress response, the fear, the anxiety, all of the things that are happening are going to keep you safe. But, what happens if there's a bear entering through your front door every single night, right? You're going to keep having that stress response in your body. And so this is kind of like a way that we can look at trauma and ongoing toxic stress.
Yeah.
Can you explain a little bit more about toxic stress or some symptoms or some signs that caregivers can look at in their kids that are maybe showing signs of ongoing unresolved trauma?
Yeah, absolutely. So not all stress is bad or toxic, right? Some stress is actually really useful. You can take the analogy of a kid studying for a test or a kid practicing for a really important soccer match. Before the test or before the match, they may have some stress or some worry about it, and that helps keep them focused and keep them motivated. They have the test or they have that match and the stress goes away because now it's over and they've done what they've done and maybe their team won or maybe they got a really great score on the test. In opposition to that, toxic stress is what happens when a kid is chronically exposed over and over again to severe stressors that they can't escape from. And so there's no rest period, there's no relief. And what happens is our nervous system, what we call our neurohormonal endocrine system, releases chemicals through our body, things like adrenaline and cortisol, that in the moment help to keep us alert and keep us able to respond to a stress. And that's a protective factor, right? Again, with that analogy of the bear, if we see a bear in the woods, our brain needs to tell our heart, okay, you got to be ready to work and pump hard because we're going to need to run. And it tells our eyes, okay, you're going to need to be really aware because we need to see where the bear is at all times and make sure that we get to safety. And it tells our body, okay, body, we're going to have to be able to endure a little bit of pain because we might have to run, we might have to fight, we might have to get away from that bear. But if our body keeps sending those stress signals and our brain keeps sending those stress signals and there's no break from that, there's no relief, what happens then is those stress hormones actually cause physical harm to the organs that we have. And so we can see that chronic stress and toxic stress leads to increased rates of things like cardiovascular disease, so heart attacks and strokes, high blood pressure. It can lead to increased rates of cancer. And then in the brain, we also know that that stress changes the way that a child's brain develops and may strengthen pathways that are actually toxic. And so we see increased rates of anxiety and depression. We can also see it affect things like development. So kids can have poor school performance, developmental delays, and also there is some association with autism as well. And so we call it toxic because this stress is acting almost like battery acid and it's leaking through the body and it's slowly corroding our physical health, our mental health, and our emotional well-being. I love how you mentioned, how you're approaching ACEs now is a little bit different than before. Clinically, it can be intimidating for, an adult to go in and talk to their doctors and fill out a questionnaire. And so it can even be more intimidating for a caregiver to come and do that with a kid. And especially when you talk about, culturally, the way that we communicate can be very different. And the way that
things are happening in our community are so different. And so I really appreciate the focus on how we can create conversations that really kind of come back to that root, right? So what's going on with your kid? Is this a sign of toxic stress? And there could be real life, health consequences. I think back, my dad had several strokes. He's fine, but when we thought about his health, it was always like, well, he's doing well. He eats really healthy. He works out, but he doesn't manage his stress well at all, and it's that direct kind of correlation. And culturally, we don't really speak about trauma or stress or those things. Our family has a very, you just gotta let it go and keep going kind of, or don't talk about that kind of thing. And so it's so nice that you're kind of part of this generation that we're trying to make these conversations easier and more normalized, right? So I would love if we could focus on, there are so much positive when it comes to handling and tackling toxic stress. We call them stress busters. So I would love your take on play. What role does play and connection have in helping kids manage stress?
Absolutely. So I've been fortunate enough from another colleague of mine to discover a really great program through the Weitzman Institution called Prescription for Play. And what Prescription for Play is it's a program where doctors can prescribe play to parents. And as part of that program, they give providers Lego kits that have 6 little Lego blocks to help build different things. And the hope is that the parents will interact with their kids in play, kind of describe the colors of the blocks and talk about the shapes and, interact in a way that helps create that bond. And what's so important about play is a lot of the way kids learn, especially in early development, is through play and exploring their environment, right? And so if we have a kid who is in a position where there is some scary things at home, mom and dad fight, maybe dad drinks too much. When I do this analogy, I always gender it too much. Maybe mom also drinks too much. Maybe mom has some illnesses, some medical illnesses. Say she has like heart pressure issues and things like that. This kid is experiencing a lot of really scary things and is not really in a position where they know what the outcome is going to be. And so what happens when we're in a situation where we don't know what's going to happen, our brains will create stories. And those stories can sometimes be very scary. And the reason that our brain does that is to prepare for what may come in case that we need to do something and change direction to avoid danger. What play allows kids to do is to experiment with different options in situations and see what would happen without an actual negative consequence happening. So, for example, the most common early baby play that we see is a kid rolling a ball or giving something to a caregiver and receiving it back. We'll call it serve and return in a very literal sense, right? They're experimenting with what happens if I give up this thing and then they see, oh, this caregiver gives it back to me and then I give it back to them. And it builds this relationship where they're learning, I have a person that I can share with and I can depend on to give me something back that I need. That's such an important bond that starts so early. Now, if we have a kid who, as an infant, may have been placed in foster care because they were born to a mom who was experiencing substance abuse, and the kid may have experienced withdrawal from those substances in utero, oftentimes their first weeks of life are in a NICU, in a hospital, with lots of lights, with lots of noise, with lots of beepy things, and their body is on fire because they are not regulated. The chemicals that were in their brain, the substances are, coming out of their body and they're having acute withdrawal. And so sometimes we're medicating these kids. These kids often are very irritable and very hard to calm when they're babies, when they come out of the hospital. And so we are giving parents tools to kind of make a kid feel safe. And one of the things that we first do is talking about swaddling them and cuddling them and singing to them. Now, this is not really directly play, but what we're doing is making them feel safe. And then similarly, as these kids become older, they oftentimes are very distractible, can run around a lot because they just have a hard time knowing what to pay attention to. And oftentimes caregivers will tell me, and this is a very common thing I see, I have a kid who comes who had in utero exposure to drugs, and they're now 3 and they're starting preschool, and the teachers and the parents say, do my kids have ADHD? And they probably don't have ADHD. They probably are experiencing toxic stress. And what we see is that these kids just can't pay attention to any one thing. And so they're constantly touching everything and running around and trying to explore their environment because they don't know what's going to happen. They're in a new environment. They're in a doctor's office. They're not sure if it's safe or not safe. They're not sure if there's food here. They're not sure if there's toys. They don't know what they're going to do. And so I'll bring into the clinic this little pack of Legos that has 6 little Legos in a box. And the first thing that they do is they say toys. Oh, great. And they take the box and they shake it. They tear it open and they start playing with the toys. It's almost like a reflex. You don't need to explain to a kid what play is. Mm-hmm. And what's so important about this is 2 things. One, it gives me a distraction for the kid so I can actually talk to the parent and the parent doesn't have to worry about the safety of their child. And 2, it lets me observe what they're doing through play. And it also allows me to interact with them through play. So if I didn't have those Legos there and I tried to approach this kid to listen to their heart with my stethoscope, it's very invasive. Mm-hmm. Oftentimes they may run away, they might scream, they might cry. But with the toys, I now have something that I can introduce the concept of my stethoscope. I can put it on their Lego. I can help build things with them. I can say, oh, look, let's listen to their heart. Let's listen to their ears. And that allows for this non-threatening practice and learning situation where the kids can see, oh, this is what the doctor is doing with that tool. It doesn't look painful. I can see that they're doing that. I want to try, and I let them hold the stethoscope and put it on the animal or the block or whatever. And then oftentimes they'll kind of reflexively put it on themselves because they've been in doctor's situations. They've seen it before. This is also still play. We're saying, yeah, you're doing it. And we're helping that kid to learn how to regulate and feel safe in a new situation. And we're also learning how to build a relationship where I can be a part of that kid's life and do things that may be a little scary, but we can practice and play beforehand so they know what to expect. And then they can plan and they can say, okay, this is new, but it doesn't look like it's going to hurt. I think that's okay. Oftentimes I'll do things where I'll try it on mom, try the stethoscope on mom. And same thing. All of this is play. All of this is setting up a situation where it's no big deal. Let's see what happens and let's try out different situations in a non-threatening way. And that's such a powerful way for a kid to learn because their emotional state is not kicking in. They're not having to rely on their amygdala, the part of the brain that is our fear center. So they are able to think in a way that's not being triggered by trauma or stress. And oftentimes when we're not being triggered by trauma or stress, we can have much more creative thought, much more rich experiences of things. Whereas when we're in the sense of danger, the brain's focus is to keep us safe. And so we often have very few reactions, right? We call these the stress or trauma reactions. We have fight, flight, fear, fawn, or freeze. And so I can't really examine a kid very well if they are fighting me or if they're running away. And even if they freeze, it still is not that great because sometimes their heart rate might go up and that's something that they can't control and it's an autonomic response. And so I can't really get a good sense of what this kid physically is like. And so through play, the importance of this in the medical situation is it allows me to get the kid to calm down, regulate, and allow them to explore their environment in a way that's safe and respond to it in a way that's not trauma-based, and allows me to get more accurate information. I think from a parent's side, the importance of play is it builds that really strong connection and bond that's super important, right? A caregiver is providing for every single need of an infant from when they're born. They can't change themselves. They can't feed themselves. They can't really even regulate their temperature that well without clothes and without skin-to-skin contact. And as a kid develops, they learn more things and they gain more physical abilities. And oftentimes it's through play. And so if a parent can help play with their kid and facilitate those growth moments, it helps the parent to help that kid become more independent. The other word we use for this is co-regulation, right? When you have a newborn, a parent is responsible for 100% of their co-regulation. If you take a newborn baby and you put them on a bed, if you don't feed them, clothe them, keep them warm, change their diapers, they will get sick very, very quickly. As a kid gets older, you think about your 2-year-old, your 3-year-old, they can feed themselves. So you can put food in front of them. You don't have to directly put food in their mouth, and they'll eat it sometimes if they're not picky. And you can dress them. They may be learning how to use the potty. They're learning when their body says, I'm hungry, when my body says I'm thirsty, and they can drink, and they can keep their body pretty well regulated. And as we progress through school, through adulthood, we now have an adult that can do everything independently, and they no longer need as much co-regulation. But it's a gradual process where a parent starts from 100% of the caregiving to less. And all throughout those points, play is a very useful tool to help a kid explore when they need to learn to do something for themselves, because they can practice before they have to try and fail. One of the things that we've seen through COVID and the pandemic as well was parents were suddenly hyper aware and alert of germs. And kids were having a lot of illnesses and viruses, and parents were having a lot of fear. Could my kid die from this? And one of the things that happens when kids are sick is, even if they might have been more independent, when a kid is sick, they regress and they need a lot more help and support, right? You need to, they'll be like, oh, my kid's like a baby when they're sick. It's like, yeah, it's true. You really need to take care of them. And what happens when kids are sick all the time is play goes out the door, and parents resort to their trauma responses too, of, I need to feed my kid. They have a fever. Are they sick? Do they need antibiotics? Do they need medicines? And it really just becomes, how do I keep my kid alive, rather than how do I help my kid to thrive? And I think play can be helpful here too, because medicines taste yucky. Going to the doctor when you're sick is really hard. You don't feel good. You're tired. You're not well slept. Things might hurt. They might need to look in your ear. And if you have an ear infection, that's really painful to have your ear pulled on and have a light stuck in there. And I think this is where it's been powerful to see some parents either will bring toys because they know that the doctor's appointment is going to be so much harder without play, or they'll sing to their kid or bounce them around, or they'll talk and point out things to show them to interact, to help distract them, which really helps me to do my job. One of the things that I have seen in the Native community, and it's incredibly powerful. I was really fortunate a year ago to be invited to a brush dance. And the brush dance is an important dance for the Native American community here to pray over a sick kid. And the kids will dance from sundown to sunrise, and they will chant. And I've heard that chant, and it's a very calming lullaby chant. And I've heard parents sing it at the time of sick visits. I've heard them chant it during deliveries, and it's really great. And I think of that as, it's not really play, but again, it's that same thing where we're bringing something familiar that helps a kid to feel safe, or helps a parent to feel safe, that is reminding a kid, I'm here. The parent is here. The caregiver is here. And we're going to get through this together. And let me help you figure out ways to do that.
Oh, I love all that. I think you really just highlighted the importance of connection and play, right? And play, there can be so many opportunities, like you mentioned, whether it's, a big moment of, you guys are playing together and you're co-regulating and connection, or it's community play. Although we might not call it that, because as adults, we kind of tend to lean away from the word. It kind of is. And there's so many awesome ways to find moments for caregivers to find play, to explain situations. Like you said, when kids don't know how things are going to end, they can kind of stay in that stress response. So that's why, we always talk about storytelling or puppet shows or pulling up a YouTube video that talks about something stressful, and kind of helping kids through it. With the recent earthquake, one of the biggest resources we gave families were books on earthquakes. And that's like a great way to kind of process that fear. So I love how you highlighted that. And I want to highlight, kind of like you mentioned, it's important for us as adults to find play for ourselves and for caregivers to find their joy outside of, when they're caregiving. I would love if we could close out. If you can give me what keeps you hopeful about the future of children's health in our community?
Yeah. So I was reading over your questions and I was talking with my wife the other night about this. And I was like, man, Karina asks great questions. She really thought this through. And that was one where we both paused and tried to think about what that was. And it's hard because, with a lot of what's going in the world right now, it's very hard to be hopeful. And the political atmosphere right now is making it really scary, especially for me as a provider of medical care for kids. We have people in government and leaders that do not prioritize children's health and science and evidence-based medicine. That being said, we are an incredibly strong and resilient community, both here in Humboldt and Delaware County. And one of the things that I take to heart is I've gotten to see over the last couple of years the change in how we talk about trauma and how we talk about mental health, and moving away from the stigma to it being so commonplace that people tell me their traumas without me asking. People tell me the experiences that they or their kids have had and the stressful things, and they're already weaving that into their explanatory model or their understanding of how their kid came to be the way that they are, right? We talked about common things kids see me for. In the winter, it's colds, and then all the other things, behavioral issues. Oftentimes, I'm not the one initiating the conversation about ACEs, right? Oftentimes, a parent will tell me, I think this is because this happened. And that's incredible. Whereas several years ago, when I started first doing this work, I had parents where I took care of their kids when they were in foster care. And so I knew that they had several ACEs. And then they were reunified with their parents, and I administered the screener to the parents. And the parents would say, no, my kid has not had any ACEs. And I think that was from fear of something happening. If they said that that was what had happened, maybe they were worried their kid was going to be taken away again, or maybe they were in denial, or maybe there was some stigma where they felt ashamed of that. But now it's in the open. It's like, you can walk down the street and people will be like, hey, how's it going? My ACEs score is 8. And they're like, oh, hey, great. Hi, mine's 5. What are you doing for skills? Somewhat jokingly, but no, like really, honestly, that's something I'm really hopeful for, because the more we can talk about it in a way where it's no big deal, it's something that is, and it happened, right? It's in the same way as saying like your identity, like I'm a Filipino American, or someone saying like I'm, Yurok, or I moved here from the Bay. Any sort of identity that is not associated with negative stigma that we can talk about in an open way allows us to better interact as medical providers, because we can be sensitive to that, right? And I think about my colleagues who are really still really afraid of doing universal ACEs screening, of asking these questions, because they say things like, well, I'm really worried. I don't want to like traumatize them or bring up stuff and then not give them anything that can help them. Or like, what am I going to do? Well, who am I going to refer to? And I think it's been really reframed now as, these are people, and these are ways in which we can understand a person. It's not the only way, right? We're not defined by our trauma, but it shouldn't be something that we're ashamed of and hide either. The other thing that I'm hopeful for is there are so many people in this community who have experienced ACEs and significant trauma and have had toxic stress, who are doing the work to help repair and heal. Right. So what's great about that is, because it's so personal, I know that these people are going to give their best and their 110% to the work that they do, because it matters, because it's something that they had experienced because it's something that they had needed. And so we have incredible community-based organizations. Shout out to Humboldt First Five. Shout out to some of the great therapists we have in this community. Shout out to the playgroups. These are people who know how important this is and wish that this was there when they were young, and are trying to dream and build something so that kids now who are experiencing this trauma have something that can help them repair and heal. And for the parents as well, right? Because the other part of the traumatic experience is that it's not always based out of a negative intention of the parent, right? I think a lot of people will hear a kid has trauma, so that means that the parent was a bad person. They did trauma to this kid, right? How can someone sexually abuse a kid? How can someone hit a kid? And oftentimes it's because of intergenerational trauma, where this had happened to that adult when they were a kid as well. And that might have been what they learned from that situation, is when you're angry, you hit. And so I'm also hopeful that as parents have these traumatic experiences with their kids, either being causers of trauma or being the parent who was in a traumatic situation, we are now talking about it and have opportunities for these parents to repair that relationship with the kid, which is super important. So those are kind of the two most things that I'm hopeful about. I think the other thing that I'm hopeful about too is it's not just our community, but it's in social media. You hear kids, I'm not going to razz too much on Gen Alpha, but I take care of a lot of teens, and they come in and say, "Oh, I'm just so stressed, doctor. My mental health is not good right now. I'm just like, my anxiety is off the hook." And it's like, okay, we're using some terms, and maybe it's a little psychobabble, maybe it's not, but it's something where they're acknowledging their emotional state and acknowledging that they may not be in their best place because of their emotional state. And that takes courage. And it also takes a lot of insight to say, I'm going to pay attention to how I feel, and I'm going to be curious if the way I'm feeling is affecting the way that I behave, right? That takes a lot of people time through therapy, cognitive behavioral therapy, dialectic behavioral therapy, to even recognize that our feelings matter and that our feelings affect the way that we act. And that our feelings might have come from a place of trauma or stressful experiences. And that there are things that we can do to change that. So I just really appreciate that, like, the youth are talking about it. And maybe they're using it as hashtags, or maybe they're using it as lingo to fit in, but I don't really care. Because if we can use that shared lingo, if we can use those terms and really get people to start paying attention to how their internal state is, that's a good thing.
Yeah, I love that. I think kind of how you mentioned, in a time where language is being censored, I think this is how we fight back, right? We normalize talking about how we feel. And that's how we kind of understand each other. So I really appreciate those points. Is there anything else you'd like to share that we haven't covered?
So one of the things that I want to share is that I think not a lot of parents hear that they're doing a good job. And I think a lot of parents feel that they're not doing a great job, right? I want to approach the parent who is struggling from a place not just of compassion, but of really truly understanding that everyone is doing the best that they can in that moment. And the reason why they might not be doing as good as another parent, or comparing themselves, or their kids are struggling and they see these other kids in school and they're not struggling, is they might have experienced a lot of stress and trauma as a kid themselves. And so it's like also a really important thing, I think, when parents talk about their kids' trauma, is to examine their own trauma. And why this matters is because I think it gives parents the compassion to understand that, like, they may not have been in a position to learn the skills to be a parent, right? If we think about the analogy again from a baby needing all the co-regulation from a parent, 100% of the support to being an adult. If you don't get all of that support in the beginning, you're not going to be 100% when you become an adult, right? Age is just a number. But I think of pediatrics as a developmental stage all throughout lifehood, right? And when you become an adult, there's this assumption that, like, you should be able to have a job, you should be able to take care of your family, you should be able to manage your own health, and you should be able to manage your own mental health. That's not always the case. And so oftentimes I have a lot of parents who are trying, and
Mhm.
I'll take trying any day of the week over not even trying. And the fact that a parent comes to me with a concern about their child is the starting point to say that you are a parent, you are a caregiver. That's the first part. If you didn't care, what I oftentimes will see is a kid who's struggling and their parents may be a little dismissive and say, like, oh, it's just a phase or there's nothing wrong. 100% of the time, I'd rather take a parent who's maybe a little over anxious and thinks that there's something wrong with their kid, and we can work on identifying their strengths and saying, here's why this behavior is coming up. This is a totally normal developmental phase or whatever. The terrible twos, they're a toddler, whatever. I'll take that because there's a moment where I know that this parent is concerned enough about the kid to take them to someone else and say, can you help me?
Mhm.
And that's all that we can do, right? We can do as good as we can until we don't have anything else. And then you have to ask for help. And I think that that is a good job. A good parent is not necessarily someone whose kids are well behaved and their kids feel loved and they're dressed all the time and they're never dirty and they eat all of their vegetables. A good parent is someone who will deal with a kid wherever they're at and will walk with them and help them to get to become an adult and support them and co-regulate, right? And I think a good parent is also someone who recognizes their shortcomings and their strengths and knows when to ask for help.
I think we talk so much about guilt and shame when it comes to caregivers and parents. When we do parenting classes or at playgroups, it's a thing that comes up so much. And I think you just highlighted one, repair is forever. If you feel like there is a moment that you didn't love how you responded, maybe you feel like you weren't present. I mean, repair is never ending. Acknowledging a situation and being able to process that with your family is forever. And also, as people of the world, self-compassion is so essential for us.
There's a couple books that I want to shout out. And it came up in a meeting actually recently, and we're going to cut some onions for a moment. There's a book by a woman author named Shanda Ibn Ghosh, and the book is called You Weren't There. And the book is about a bunny who has a separation from their parent and how they struggle with that feeling. And in our community, we have some of the highest rates of ACEs and toxic stress. We also have some of the highest rates of foster placement of children. And so there's a lot of separation. And oftentimes these kids are reunified with the parents, which, that's great. That's important. But there is that moment where there needs to be repair, and that's a lifelong thing, and parents may oftentimes not know how to say sorry or how to deal with that or how to deal with that guilt of you weren't there. And this came up and I was mentioning this to a parent and she's like, oh yeah, I got that book. In fact, I started making a picture book for my kid of the story of their separation. And she said, I think it's really important for him to know, because I think there is this guilt and shame that, yeah, a parent might not have been in their best, right? They might have been using drugs. They might have been not neglectful. They might not have been able to be a caregiver at that time. And when kids are reunified, the hope is that that parent now is in a better place to be a caregiver and that they're safe. And so I really thought that this was a beautiful repair, in that this mom is trying to say, like, yeah, let's talk about that story. I'm not going to hide it. You're going to find out about it at some point. But if I have control over that narrative and that story, maybe we can have some empathy and you can understand, like, I was trying. I was also struggling. I had issues. I'm not going to lie, but I was also trying, and I'm here now. And I think that that is something that goes unrecognized so much, right? We in the medical community are really good at this, at stigmatizing parents and like, oh no, here comes this hot mess mom. Oh, we write it into the chart, kid with history of in utero substance exposure, maternal exposure to hepatitis C from IV drug use, and maternal homelessness and mental health disorder, parent with bipolar disorder. Yeah, that's all there. That's true. That's the parent. But we also don't write into the chart what they did to repair and why they have this kid again now, and what they're trying to do to build a relationship again. right? So if this co-regulation wasn't there in the beginning, we have to start back with that co-regulation. And how do we make that relationship something where the parent feels supported and they can support the kid, right? And that's how I think of it, is like, well, okay, maybe this parent needs some arms under their arms to hold up that baby.
It isn't easy going to the doctor for anybody. Well, I mean, for a lot of folks that have maybe experienced some providers that they didn't feel that really cared or that were showing up for them. So I think it is so important to have someone like you on the podcast to really show families that there are people there that are listening and that care. And they care outside of just what's in the chart and the questions, but they want to know your story and to really understand what's going on. So I want to say a huge thank you to not only the work that you do for the community and the kids, but also for you pushing along ACE's work and for being here today.
Thank you so much. Thank you. I really appreciate this, and I feel really honored to get to speak on this topic.
Stay connected with First Five Humboldt at First Five Humboldt on Instagram and on Facebook. Check out our website for additional resources. And if you're in community or if Dr. Michael Mangahas is your pediatrician, go ahead and say hi. Thanks for listening, and we'll see you guys next time.